Hi, everybody. Welcome to WSPOS Independent Medical Education Program. It's the first of its kind, and it's a comprehensive update on myopia management. I want to thank very much our sponsors. Luxottica, our gold level supporter, Hoya, silver level supporter, and CooperVision, bronze level supporter. Now, if I keep cutting out, it's because we're a very global panel. I am sitting here in Mendoza, Argentina, and so I apologize in advance if I keep cutting out. I promise you I will come back in, and I hope you can hear me right now. So let's talk about the education forum that we have here. The IME, what is an IME? It's an education forum, which is a resource for evidence-based educational programming featuring symposia, podcasts, e-learning, supplements, videos. We hope that you'll find this very, very entertaining and educational, what we call now edutainment, and we hope that you'll be along for the ride with us on this amazing program. So this is what day one looks like. There are 2 days. Remember, there's day one today, day two tomorrow at the same time. Day one, we've got an amazing faculty that I'll be introducing as we go along, and there'll be time for discussion. There'll be time for Q&A. So please do put your questions and answers into the appropriate slots in your viewing screen. So this is our panelists and our speakers from around the you can see, I think, that we've got people coming from all over the world. This is a truly global problem, and it's a global panel. Okay, and here are the countries that are tuning into WSPOS IME. I am just amazed how many countries we've got people registered from, and I think it's going to be really quite exciting. So we sent out a myopia survey at the time that you registered, and it was completed in November, as you know, 11 questions. We had 326 respondents from 64 countries. That's really quite remarkable. So what's the prevalence? You know, on average, people are seeing about 29 pediatric myopia patients per month. Some are seeing almost a quarter are seeing more than 50. That's quite remarkable if you think about it. So now, what about the frequency of how much concern there is? And you can see that almost 85% of people are concerned or very concerned about the effect of myopia and how we can deal with it in our patients. So what about treatment strategies? Now, I think this is the one that is most revealing. People are very well aware of behavioral modification and very well aware of pharmaceutical options, but the optical designs of some of the new lens spectacles, orthokeratology, and contact lenses seem to be, I would say, less known to people. And we hope that after the 2 days of the IME, that will change, and we'll be able to see that change. So what is the most common recommended behavioral modification? Well, spend more time outdoors and reduce time spent on devices. Again, we'll be hearing from the world's experts on behavioral modification, and I hope that you'll be able to learn a little bit more. So right now, what I'd like to do is I'd like to do some audience response questions. And so please do respond as we go along. Here is the first question. Where do you practice? We're going to give you about 15 seconds, and then you can hopefully tell us, where do you practice? Where is your main area of practice? And I'm answering it live as well, so we can see what the results are. Okay, so what I'm looking at is we have, as percentages, well, Europe beats everybody. 42% of the listeners, 44% are from Europe. We have Asia Pacific 16, Indian subcontinent 17, Middle East 10, North America about 10%. I hope you can hear me again. And Australia and New Zealand, I think everybody's asleep, but we've got a few people, but not quite 1%. But as I said, Europe wins it. Okay, let's go to the next one. Let's go to the next one. The next question is, how many pediatric myopia patients do you see in your practice each month? We'll give you 15 seconds. Remember to hit send once you've voted. Oh my goodness, this is remarkable. As the feed comes in, more than 50 is around 28%. 11 to 20 is catching up. Now they're sort of leveling out, as you can see. So more than 50, actually 11 to 20 is taken over. So that's still a significant number. If 10 years ago, somebody had said to me that we would be seeing this many patients in our practices, I would have found it really difficult to believe. Question number 3. How has the number of pediatric myopia patients you see in your practice changed over 2 years? How has that changed over 2 years? Has it increased substantially, marginally, neither? Has it decreased? What are your answers? Remember, please hit send once you've voted. And I don't think this is much of a shock. By far, 60% of people are saying, actually 58, that it's substantially increased. And I don't think that's a surprise. I think that's reflective of both the interest and the evidence epidemiologically that we have of the increase in myopia. So let's go to question number 4. How confident are you? Now, think about this and be honest. How confident are you in your ability to manage and treat myopia progression in a patient younger than 8 years? So when you see a child younger than 8 years, how confident are you that you would be able to manage that child well? Okay. Very confident, somewhat confident, neither, not confident. All right, here are the answers. Somewhat confident. And I think that, again, perhaps to be expected, 20% are very confident. And I think that's really interesting. The neithers are very interesting as well. About 12% not confident, but not confident. Okay, let's try question number. I think we've done the voting there. Okay, question number 5. How confident are you in your ability to manage and treat myopia progression in a patient between 8 and 12 years of age? 8 and 12 years of age. Slightly different. Now, I guess think about the age difference and how that might affect your confidence level. I think this is interesting. We've got much more confidence here. We've got very confident and somewhat confident, running at about 90% or just under. Yeah, about 88%. So we hope that at the end of day 1 today, at the end of the 2 hours, we'll be able to evaluate how your confidence and perhaps some of the information you have, how that might change. So let's get to the last question. Okay, how strong is your understanding of the latest treatment options for myopia management, including orthokeratology and multifocal soft contact lenses? And by multifocal, we mean the newer design contact lenses. Remember to I hope you can hear me again. So I think this is really interesting. There's a moderate understanding in about 45%, but little understanding in almost a quarter. and at 20% have a strong understanding or very strong understanding. That's about 25%. So I think that this audience response has been really very, very enlightening. And I think the next 2 hours will hopefully help all of you at some level in understanding myopia management a little bit better. So thank you very much for participating. And it really does give me great pleasure to introduce Ian Morgan, Professor Ian Morgan, who is at the Australian National University in Canberra. And because of the time at night, Ian is going to have a pre-recorded talk about the global epidemic of myopia.
Hi, my name is Ian Morgan, and my task today is to introduce you to the global epidemic of myopia, talk about its causes and about its challenges. I do have to make two declarations: a consultancy with EssilorLuxottica and travel support from Everrise. Next slide, please. For many years, myopia was regarded as a minor problem, easily fixed with glasses. But what's changed that view of myopia are the massive increases in prevalence that have taken place in certain parts of the world, specifically East and Southeast Asia. These two graphs show the sort of thing that's happened. Since the Second World War, there's been a progressive increase in the prevalence of myopia in places like Hong Kong, Singapore, South Korea, and Taiwan, from about 20% in children completing high school up to about 80%. This process was delayed in mainland China by the Chinese Revolution, and particularly the Cultural Revolution. Delayed the process by about 20 years, but once economic development started, education had to expand and myopia took off. A key message from this is that the prevalence of myopia is strongly influenced by social factors and political decisions, and this makes future predictions rather difficult. Next slide, please. There's also an epidemic of high myopia, 6 diopters or more. This seems to arise because one of the features of the epidemic is increasingly early onset of myopia. You can see in these data from Taiwan that roughly 20% of children or over are now myopic at the beginning of schooling. And this translates through myopia progression into an increasing prevalence of high myopia that seems to first appear, given the progression rates, at around the ages of 10 to 13. The key message: early onset myopia can lead to progression to high levels of high myopia. Next slide, please. Now, I don't need to tell you in detail about the pathological changes that are associated with high myopia. You'll hear more about this in later talks. The key message on this point here is that at present, the only way to reduce the development of pathology is to reduce the onset and progression of myopia. Next slide, please. Now, extensive research has documented two major environmental risk factors for myopia. One is educational pressures. There are a whole lot of markers of when an education system is putting too much pressure, lots of homework, competitive high achievement pathways, and extensive use of after-school tutorial schools. The other fact that's been documented, and you'll hear a lot about this later on, is limited time outdoors. In part, this is induced by a heavy educational load in East Asia, but it's also combined with cultural attitudes that tend to favour avoiding sun exposure, even outside of school hours. These two major causal factors are really key to the epidemic. You'll see in the literature a lot of mention of ethnicity, but extensive epidemiological and genetic research has shown that what we need to be concerned about is a cultural emphasis on education rather than the underlying genetics. Screen use is talked about a lot, but in fact, the epidemics of myopia became clear in the 1970s and 80s, well before screen use became common, and even earlier relative to the use of smartphones, which are getting a lot of blame at the moment. Living indoors is also a factor as countries urbanise, but where it's not yet clear whether living outdoors just means not being outdoors or whether living in enclosed spaces adds further risk. Next slide, please. Now, some projections suggest that by 2050, almost 50% of the world's population could be myopic and around 10% highly myopic. Because there's a tendency in the literature to take this as established fact, I do have to stress that these are projections. They may or may not come true. There are certainly upward pressures coming from the emphasis on education in societies today, and also from the move towards urbanisation and indoor living. But the reality is already worse than this in East Asia, including China, Japan and South Korea, and Singapore in Southeast Asia. In these areas, already 80% of the latest cohorts of high school graduates are now myopic, and 10 to 20% are highly myopic. And this will inevitably spread throughout the entire population. Next slide, please. This poses two major challenges. We need to reduce the onset of myopia and slow the progression of myopia. As usual with a situation like this, there are two different streams of approach. The first is a public health approach, increasing time outdoors in schools and societies. This is already being tried in places like Taiwan with great success, with 50% reductions in the prevalence of myopia at preschool and primary school level being reported. The other arm of this is, of course, to somewhat change the education system to reduce educational pressures in the early years, and this is happening extensively in mainland China. The third arm of this approach is, of course, the development of systematic screening and referral for clinical assessment and treatment. On this front, there's been a lot of progress. You'll hear a lot about it later on. I'll simply say that current technologies seem to permit at least a 50% reduction in progression over several years. And the key question here, which is really at the front, cutting edge of research, is should treatment start prior to the onset of myopia in the pre-myopia stage? Can I have the next slide, please? Now, I do need to say something about genetics because, of course, for many years, myopia was believed to be under tight genetic control. But this idea is just not compatible with the rapid increase in prevalence that have been observed in recent years. A major role for environmental factors is now generally accepted. There are certainly very rare mutations of large effect size that account for a very low percentage of often severe and early onset myopia, low percentage, perhaps 1 to 2% in any population. And of course, you'll tend to see these in paediatric ophthalmology practices. In addition to this, genetic studies have identified several hundred common SNPs, generally with small effect sizes, that account for around 20% of the variance in school myopia. But the important thing to realise about these is that this level of genetic load is not, in most cases, sufficient to cause myopia. Could I have the next slide, please? So in fact, most children require some exposure to environmental risk factors to become myopic. In general, this is consistent with the fact that in general, the prevalence of myopia is low, once again, at most 1 to 2% in societies where there's little or no formal education. It's also consistent with how myopia develops in societies with more education, because there is really very little myopia before children go to school. And if they don't go to school, then this situation persists. But if they do go to school, then myopic shifts in refraction associated with being a school child lead to the development of myopia. Let me give you an example from China, which certainly has an epidemic of myopia. There, the prevalence of myopia in children starting school is under 3%. And the mean spherical equivalent is in the range of 1 to 1.5 diopters. So they need to change on average anything between 1.5 and 2 diopters to become myopic. And this, in the intensive education systems in the region, takes 3 to 4 years. In the rest of the world, it often takes much longer. Now, it is possible that children with a higher genetic load are closer to the myopia cutoff and therefore will tend to be the first to become myopic, but more research is required on this issue. Next slide, please. So in summary, there's definitely an epidemic of myopia and high myopia in East and Southeast Asia, and it may be spreading significantly throughout other parts of the world. This poses the twin challenge of slowing onset and progression. Public health prevention is being actively and successfully pursued, and clinical approaches to the control of myopia progression offer at least 50% reduction over several years. A major clinical issue is whether clinical intervention before the onset of myopia can be used to lower the prevalence. Thank you very much.
Ian, I always love hearing you speak, and I'm so grateful for your explanations. Much, Ian. Thank you so much, Ian, for a wonderful talk. So that was great. It gives me great pleasure now to introduce Jay Chablani, who is a friend and a colleague, Director of Clinical Research at the UPMC Eye Center at Pittsburgh. And Jay is going to talk about the real problem, more high myopes. Jay, thank you so much.
Thanks, Ken. Thank you so much, Ken, for inviting me for this meeting. At the outset, I would like to thank WSPOS. This is my first meeting at WSPOS, and I want to congratulate the team, especially Ken, who has built up this great organization with great concepts and great aim for the organization. So I'll be primarily talking about high myopia and its relationship with axial length. I do not have any financial disclosure relevant to this presentation. This is the outline of my talk. I'll be starting with basic definitions, then we'll talk a little bit about axial length and myopia, then myopia associated conditions, and what is the overall impact, chipping in a little bit what Dr. Morgan spoke just now. So we define high myopia as a spherical equivalent of more than -6 diopter or worse, which corresponds to axial length of more than 26 millimeters. And it can lead to severe complications, which we'll be talking eventually over the course. So axial length is the #1 determinant of refractive error. It has been shown to be having strong correlation with myopia as well as myopia progression. So if the axial length is longer, there is a more severe degree of myopia. We all understand that the eye grows with age. We grow from almost 16.9 to 23.6 when the eye grows from infanthood to adulthood. However, not everybody gets high myopia because of the compensatory changes which happens, and it changes this offset. However, if these compensatory changes were not there, every millimeters of axial length increase will lead to almost 2 to -2.5 diopter of myopia. What about children? The study from Europe has shown that axial length increased rapidly in children that were myopic versus hyperopic. They showed that 354 children had accelerated axial length growth of almost 10 percentile between age 6 and 9, and almost half of these kids became myopic by age 9. What about adults? We all believe that the axial length does not increase in adult, but this does not hold true in eyes with posterior staphyloma. And this study from Japan showed that older individuals with posterior staphyloma are more susceptible to greater increase in axial length, and eyes with more than 26 millimeters have been found to have an increase in axial length of around 0.03 to 0.06 millimeters per year. And in this figure, you can see that the distance between the central scarring and the peripapillary atrophy has increased over the years. What about the anatomical changes which happens normally in any eye? You can have choroidal thinning, which could lead to choroidal neovascularization, lacquer cracks, and it can also lead to scleral thinning, which can increase the posterior staphyloma height. What about the secondary changes or secondary conditions which happen in eyes with myopia? Let's start with glaucoma. Eyes with myopia have higher risk, almost 1.5 times more likely to develop glaucoma compared to low myopia. But not only that, it is sometimes very difficult to diagnose glaucoma in these eyes, as well as to define the target IOP in high myopic glaucomatous patients. What about cataract? Cataract happens almost 17% more likely in eyes with glaucoma, eyes with high myopia compared to moderate myopia. And the cataract in these patients present at a much younger age, and I'm sure that we all are aware the complications or intraoperative challenges which are faced while operating plain cataracts in these eyes with high myopia. Degenerative myopia is one of the biggest challenges which we face in our retina clinics. You can have very minimal changes at the macula as shown on the figure on the top left. And if you look at the progression of this disease, it can lead to almost advanced myopic maculopathy as shown on the right bottom figure. These patients are very difficult to manage. There is no treatment option to treat these advanced myopic maculopathy eyes. Myopia also makes these eyes prone for retinal detachment, and operating on these eyes becomes a little bit challenging considering the anatomical changes, and you can see that sometimes they present with a large giant retinal tear as shown in this figure. What about choroidal neovascularization? High myopic patients tend to present with a sudden vision loss, especially for their reading vision because of the presence of choroidal neovascular membranes, which needs to be treated urgently because they tend to scar down quickly, unlike wet AMD. So therefore, these eyes needs to be treated with anti-VEGF therapy sooner than our type 1 typical wet AMD cases. Overall, I would say that high myopia can lead to uncorrectable visual impairment, and this study clearly showed that 39% of high myopic patients developed uncorrectable visual impairment by age 75. And this visual impairment was certainly associated with increasing axial length, and if the axial length was more than 30 millimeters, then almost 90% of these patients developed uncorrectable visual impairment by age 75. What about impact on quality of life? This is just to chip in what Dr. Morgan mentioned. Very important that these visual impairment can lead to issues with reading, mobility, and emotional well-being. And a study by Wong et al. In 2021 showed that severe pathologic myopia could lead to difficulty in performing simple tasks such as playing games, recognizing friends, and seeing stairs. To summarize, axial length plays a vital role in determining how severe myopia will be. Both children and adults tend to have axial length elongation, which can lead to certain anatomical changes in choroid and sclera. However, the secondary conditions associated with high myopia are not uncommon, including glaucoma, cataracts, retinal detachment, and myopic maculopathy. Overall, pathologic myopia has a devastating impact on quality of life. Thank you so much for attention and giving me the opportunity to speak to you guys.
Thank you so much, Jay. As always, a fabulous talk. And real food for thought, real food for thought. So thank you again. Okay, so now it gives me great pleasure to introduce Dr. Ramesh Kekanuya, who is the director of Child Sight Life, the Child Eye Unit at LV Prasad Eye Institute. And he's going to talk to us about the changing views on the impact of myopia. And then after Dr. Kekanuya's talk, there'll be a panel discussion. Can I just remind the audience, on your live view, you can see at the top of the video, it says Q&A. And if you click that, you can put some questions in and we will try and answer as many of those as we can. Ramesh, thank you so much.
Thank you, Ken. Welcome everyone for this webinar. People have joined from all around the world. I'll be talking about changing views on the impact of myopia. I do not have any financial disclosure for this presentation. So in 2022, when you examine this child like this, sometimes we'll have to do it as pediatric ophthalmologist. What do you expect? You want the child to be emmetrope, or you will get myopia, hypermetropia, or astigmatism. Irrespective of any questions, any diagnosis, what people ask, the parents ask is whether it's progressing or not, whether this condition will remain like this or not. That's the question we have to face every day in the clinic. If you look at the myopia epidemic, we call it as, it's a cause for concern because there are reasons children are developing myopia at an earlier age. As Jay and Ian said, there are increased risk of secondary conditions like myopic macular degeneration. And in fact, it causes increased cause of burden. The slide is very important. You can see the world map there. I'm not going to talk about each of those. If you look at the current and the projected at 2050, the prevalence of myopia by region, it's increasing. Southeast Asia or East Asia, it's more. We talk that, in this African continent, it's less. If you look at the proportion, which is relative proportion, it's high among all the countries. So this is one of the important things to note. Secondary disorders, specifically retinal, as Dr. Chablani said, there are many things which can be caused due to this, specifically because of the increase in the axial length. We don't want this eye to grow. That's what we are trying to reduce the growth of this axial length. If you see, it's an economic burden because cost of treatment with optical devices is huge. Then frequent and long-term management, because in some of the countries we have seen even the spectacle renewal becomes difficult. There will be some grants for the initial spectacle correction, then the renewal becomes difficult. It leads to loss of productivity for the patient as also sometimes parents. As you all know, some of you would be from developing countries. All in all, it decreases the quality of life and also loss of independence. The quality of life, I just want all of you to look at this 6 or 7 segments. Myopic patients, obviously wearing a glass is not a convenient thing. Symptoms wise, they always have visual symptoms. Early in the morning, you have to search for the pair of glasses and then only you can start anything. It limits your activities, and it causes a lot of emotional concerns, maybe in the interpersonal relationship, due to social issues, and quality of vision of seeing clearly and seeing perfectly could be affected. These are all affected to quality of life. This is what I'm saying here: myopia, progression, and pathological. If you see, the first one is all children with blue color there. They are the people who develop myopia. You don't want them. You see on the green, progressing to the next stage. You don't want them to progress. And the last thing, if possible, can you prevent this high myopia and pathological myopia? What do? As Ian said, pre-myopia is very important. Can you prevent this development of myopia? Can we identify these high-risk children and then start the treatment? And the final one, can we identify some of the markers beyond the axial length where they will go into the high myopia or pathological myopia? These are the questions which are there. Myopia is definitely a public health problem because it begins early in life. It affects large number of patients. For sure, it impedes education, development, and quality of life. Even the cost of glasses is a major cost to the society, leave alone the anti-myopia strategies. If you look at the cost itself is very high. We have comprehensive approach with different gadgets. I'm not going into the details of this. I just want to say a few words about what are we doing for this, myopia progression prevention at the global level. I just want to name few. There are many more. Brian Holden Vision Institute in Australia, International Myopia Institute, come up with closely, they are collaborating with the WHO and come up with various white papers. American Academy of Ophthalmology Task Force, specifically looking at white paper, education, advocacy, research, and public health. SNAC, a lot of Johnson & Johnson Vision and the SNAC and the SERI collaboration, along with, if you see the Hong Kong Polytechnic University, CVER, they're coming up with a lot of research and also strategies to prevent. Obviously, at India, Myopia Center at Ali Prasad Eye Institute, both in Hyderabad and Vijayawada, looking at the comprehensive approach from the developing countries perspective as well as developed countries, and also a contribution from National Eye Institute. There are more to add to this list, but the International Myopia Institute Task Force defined myopia less than or more than or equal to 0.5 and less than 6 diopters, which is a threshold for uncorrectable vision loss, which can increase beyond that. What do we do when a patient comes? Family history, lifestyle, sports, academics, parental concerns. Define whether they are hypermetropia, pre-myopia, or myopia. Then come up with the strategies for each of them so that when they have myopia with the spherical equivalent of 0.5 or less, then we start. But for us, even the hyperopia as well as pre-myopia is very important. There are stable people and there are progressors. The patients who have myopia progression, this is the base up you can see in the cartoon. There is axial length, there are natural strategies. Whatever you do, early intervention is the key in terms of increased outdoor time, slow myopia progression in children with low or mild myopia, using various strategies. As Dr. Chablani showed, if they reach into advanced stage, we need to go for anti-VEGF and other treatments. In summary, I just want to say that myopia is a global epidemic. It poses economic burden and results in decreased quality of life. There are many research initiatives to address myopia. The clinicians and scientists working very closely for this, as we did for COVID pandemic. Early intervention is the key. Progression may be slowed and or prevented to a meaningful or acceptable level. This is the myopia mantra: master, manage, measure, monitor. Thank you so much for all the attention. I'll be taking questions later. during the panel discussion. Thank you so much.
That's fantastic. I love listening to you, Ramesh. You always have, there's always a catchphrase that you develop that always, I like that, the myopia month. I think that that's going to be, I can see t-shirts now, WSPOS, the myopia month. Fantastic. So if we can have all the faculty on, we've got them, fantastic. Okay, so a couple of questions that have come up, and I would like to address some of them addressed directly to some of our speakers, but I'm going to pull everybody into the discussion. So Ian, are you with us? I know it's late in Australia. I think you're with us. Are you, Ian? Maybe.
Hear me?
Yep, we can hear you.
Yes.
Ian, the question for you is, what exactly did the Taiwanese kids do to reduce myopia by 50%? This, the person who asked the question says, I live in a cold, dark climate in winter. Parents are asking, how much light is enough?
Well, that's obviously one of the big questions. The Taiwanese children simply get outside much more during school hours. That's where you have good control over what children are doing. Parents can play a part, but the most reliable intervention is obviously in the school base. In Taiwan, their current aim is to get children outside for 2 hours a day. It seems to be producing spectacular results. They also do pay attention to viewing distance, but they've done that for many years, and it really had little effect on its own or even in combination with other things. It does seem to be that time outdoors is the key.
Okay, so there's another question for you, Ian, and I'm going to pull in the panel. It says, again, I think it's a relevant question. It says, the person who's asking this question, anonymous, says, Ian, given the hot climate where I am, most of the outdoor activities are after sunset. Would that have the same effect in control of myopia despite the absence of sun? I think I know the answer to that, but I'm going to let you answer it.
Yeah, the causative factor or the preventive factor seems to be exposure to light. So if you're outdoors after dark, then that's unlikely to exert any protection. There is some evidence that physical activity itself could be protective, but the problem with that evidence is that nobody has ruled out that it's in fact doing physical activity outdoors that is really important. So I'm sorry if climatic limitations, and that can occur for all sorts of reasons, make it impossible to get outdoors in the light, then prevention is going to be very difficult.
Okay, so let's put one thing to rest. I'm going to ask the whole panel, and I'd like you to give me your opinions. Are we all agreed that a minimum of 2 hours daylight exposure every day is perhaps a foundation of behavioral intervention for slowing myopia progression of childhood? Mark, I'm going to pick on you first. Agree, disagree?
I think we know that outdoor activity is good medicine, but I think we're uncertain as to the exact dose. And even if we know the exact dose, achieving that dose in the population may be a challenge, because even when you have programs that encourage outdoor activity and compare, say, 1 hour and 2 hours, the 2 hour, the children assigned to the 2 hour group get nowhere near that. So that's my long answer to your simple question.
No, it's a great answer. Cheryl No from affiliated to NUS in Singapore. Lovely to have you here. Singapore, was allegedly building schools with transparent walls or translucent walls. Is that true? Is that what's happening in Singapore?
I don't think that's exactly true, but I think in terms of the amount of exposure to sunlight, it's difficult to define the amount of time the kids need to spend outdoors because it also depends on the intensity of sunlight as well, the lux level. So if they go in the evening when it's very cloudy, it's quite shaded, perhaps they may need more time in order to achieve the same level of benefit as if you go outdoors when it's brighter, it's more sunny. Yeah.
Okay, and Erin Tomiyama, lovely to have you a part of the panel. Erin, what do you tell parents or what do you advise your colleagues about exposure, daylight exposure?
Yeah, when it comes to those pre-myopes, the people that, you know, haven't necessarily developed myopia yet, we really have to rely on the behavioral changes that we can instruct them on. And so I do tell patients and parents, you know, get outside as much as you can, ideally 2 hours a day. But as Mark mentioned, it's not necessarily always feasible for them.
Hi, I hope you can hear me.
Yeah.
Okay, Erin, you said something really important. There is some evidence, and Ian, I'd like your input, Ramesh yours, and Jay yours as well. There is some evidence that if you're a myope, let's say you're already -2.5, that daylight exposure has less of a slowing effect than if you were a pre-myope with a family history of myopia. Is that what you're saying, Erin?
Yeah, when we look at the studies, it's definitely, there's clear evidence about delaying the onset of myopia, but the evidence as far as slowing the progression once you've developed myopia is less clear.
So Ramesh, what is your approach?
Yeah, Ken, we have a population who study in urban as well as rural area. We see this clear distinction between the rural and urban. In terms of my advice to the parents of all the urban parents with myopic kids, I completely agree that effect of outdoor games, the dosage, whatever works better in pre-myopes than who has already developed myopia. It does not mean that they should, stop doing outdoor games. But the practical situation, I don't know about other countries, but in Indian scenario, the schools mostly are 6 hours, 6 days a week, even weekend. I'm talking about most of the schools. It's not all schools. And the problem is that physical training period happens mostly towards the evening, towards the sunset. So these are the challenges we have. Having said that, the dose, absolutely, we don't know. We try to tell them that during weekends, go outdoor as much as possible.
Okay, that's fantastic. So Jay, we got a question for you. Christiane Rolim de Moura. Christiane, hi from Sao Paulo, Brazil. She says, this information of 40% of low vision at 75-year-old in high myopes is amazing. How was it calculated? Can you post the reference?
I can certainly share the study, and this is the study which was published. Just give me a second. There were a couple of references, and this was a study published by Tidman et al. In JAMA Ophthalmology. I can share the reference on the screen.
Don't worry about that. We'll get it on day 2. We'll make sure that everybody gets it. That's not a problem. So let me address the elephant. Elephant in the room is this: we have got good evidence that there's a global epidemic. We have good evidence that there's an impact on children. We have good evidence that the longer the eyeball, the greater the risk of ocular morbidity. Here's my question to you, all right, to the panel. Do we have any evidence right now, as it stands in 2022, that slowing the progression of axial myopia will prevent or does prevent any of the morbidity that Jay Jablani very nicely discussed?
Jay? Yeah, I would say the couple of the studies which I mentioned, they all have, unfortunately, they all have shown the retrospective analysis, or I should say, when the changes were shown only when the axial length was already there. However, there was one more study which I could not include because of limitation of the time, was there any anatomical change which happened when the kids were having a sudden spike in the axial length, which primarily happened just 1 year before they got into something called high myopia. So that certainly will lead to anatomical change. And obviously, like I was trying to explain, that when the myopia develops, there are certain anatomical changes which happen in the choroid and the sclera, which eventually leads to the pathological changes. So I'm pretty certain that if we really stop the progression of this axial length elongation, we are going to prevent these anatomical changes, which will prevent eventually the pathological change.
That's great. That's great. So Ramesh, you had his hand up first, and then Mark.
Yes.
Go ahead, Ramesh.
Okay. Can I look at this in a little bit differently? When a parent comes, everybody's question is, doctor, is this going to grow? Is it the power is going to increase? They don't talk to me about, okay, they have a high risk chance of retinal detachment or macular degeneration. What their question is, my sister was -2 at the beginning. She has gone up till -8 or -10. None of them, most of them don't talk about the complications. They want reduction. My only answer is, I can't say directly this will have an impact, but whatever patients, that 10% can go into high myopia and that complications. But the question for me is, for that child, in 2022, I have 14 or 15 options to reduce it, which is evidence-based. When it is there, it's my duty to tell the parents, these are the options, it's available. It might help the child to reduce the progression. I will not say that avoid the progression or completely stop the progression, so that they can make their career choices, maybe in defense, maybe in aviation, or some of the high situations. At this point of time, I do not know the answer in that 10% of the population, whether I can prevent by putting them on optical or pharmacological treatment. This is my discussion with the parents, Ken.
And I think that's fantastic and very useful. Now we're running a little bit behind, so 30 seconds each. Mark, you first, and then Jay.
Well, the evidence clearly shows that each additional diopter of myopia increases visual impairment by 30% later in life. Now, whether reducing the level of myopia earlier in life will have a benefit on that vision, we don't know, and it's unlikely we will never know definitively, because intervening in a child and looking at outcomes in late adulthood presents a methodological challenge, to say the least.
Yeah, but I think there's enough evidence that it's
Yes,
worth doing.
I agree.
Worth offering. So Jay, 30 seconds, and then we move on.
Yeah, just a quick one. I just think that this is the very reason we are having this symposium, where I, as a retina specialist, is part of this, where we can actually comprehensively attack the problem, ranging from preventing it and preventing the progression and preventing the complication. So as long as we are aware of these two spectra, we should be able to help our patients.
Listen, thank you so much. That's the first panel discussion, and we're now going to move on. Thank you so much. This is so useful, so valuable. The questions are going crazy. We'll try and answer as many as we can, but it gives me great pleasure now. We've got a pre-recorded talk from Kathy Rose, who is head of orthoptics at the University of Technology in Sydney, Australia, and she's going to talk about first-line treatment, behavioral modification.
Thank you for allowing me to talk to you today about the potential for behavioural modifications to slow the progression of myopia. I have no financial disclosures to make, but would like to acknowledge the work of my collaborator, Dr. Amanda French. Overall, environmental changes appear to be the factor that's increasing the prevalence of myopia around the world. And the three factors that are most myopogenic and most likely proven are increased level and duration of education, decreased duration of light exposure by limiting time outdoors, and increased levels of near work. Biologically, these factors have been shown very clearly to work for myopia prevention, but it's unlikely that they cease effect once a child becomes myopic. So lifestyle changes can make a significant impact. The link between education and myopia is well and long established. We've known about this since about the 19th century, and it's likely to be multifactorial. So when we look at near work and time outdoors, they are probably incorporated in this factor. So discouraging early intensive education is important, and it's possible. And talking to parents about making sure that children are not pushed into excessive amounts of homework and academic coaching at an early age is important. At a government level, I think it's important that they need to understand that one should avoid early academic streaming. In countries where the myopia epidemic took off very rapidly, say Singapore and Taiwan, academic streaming occurs at quite a young age, and I think should be avoided. Also, all massive amounts of homework when a child is young is also not good, and that should be avoided at all costs at a government level too. These factors are particularly important because we know that early onset myopia creates initial faster progression of myopia and a longer time over which myopia can progress. Studies on the effects of near work have been less consistent than education and time outdoors, but that may be due to some interaction with time spent outdoors. However, studies have shown, such as the Sydney Myopia study and its follow-up, the Sydney Adolescent and Vascular Eye study, that children who spent more time at near work and particularly longer periods of near work were more likely to become myopic. In 2015, a meta-analysis by Huang and colleagues sought to clarify this and showed that odds of myopia increased by 2% for every 1 diopter hour of near work per week. Some findings from the Sydney Myopia study contributed by Amanda French show very clearly that when the children were aged 12 at the baseline measures, if they were myopic, there was a distinct imbalance between the amount of near work and time outdoors those children were spending, while those who were remaining hyperopic obviously had a much better balance of near work and time outdoors. And this persisted when the children were followed up at age 17. So this clearly shows that the more myopic a child is, the greater their imbalance between near work and outdoor time outside school hours. And this is something that we need to pay close attention to. Screen time is currently very topical, and the use of digital devices has not been clearly linked to myopia. And we have to remember that the myopia epidemic was actually around before we had a publicly available internet. So that would suggest that the epidemic is not dependent on the presence of digital devices per se. But we know that digital device use is becoming much higher amongst children and adolescents. And so we have to ask the question, is this a new form of near work? Some jurisdictions have been attempting to restrict the use of digital devices by children, and there are recommendations on the time children should spend on digital devices, with 2 to 5 years, a maximum of 1 hour per day as per the WHO guidelines, and above that age, only 2 hours per day. This was a particular problem if spending time on digital devices substitutes for time outdoors. Time outdoors has been consistently shown to prevent myopia. And the thing that's different between indoor and outdoor environments are the lux levels. Indoors, rarely does lux get above 1000 lux, while on a cloudy day, you can have 30,000 lux outside, and on a sunny day, as high as 300,000 lux. We know that light stimulates the release of retinal dopamine, and the rather elegant work by Ashby and colleagues has shown this has a marked effect on the development of myopia. And retinal dopamine has been known for some time as an eye growth inhibitor. The direct evidence that it slows myopia progression is not quite so clear. However, several studies have now demonstrated strong seasonal effects on the rate of myopia progression, with slower progression in summer and faster in winter. And that's likely due to increased hours of daylight, encouraging more time outdoors, as well as warmer temperatures, also encouraging time outdoors, and probably also school holidays, which often occur in the summertime, and so perhaps less near work. The recommendation from a number of studies is that children should be spending something like 10 to 15 hours per week outdoors, or roughly 2 hours per day. The impact of COVID-19 lockdowns was perhaps somewhat predictable, with less time outdoors, greater amount of homeschooling involving more screen time and more near work to entertain children as well as educate children in that lockdown environment. And a Hong Kong study using a COVID cohort and a pre-COVID cohort found that the estimated change in spherical equivalent was almost double in the COVID cohort compared to the pre-COVID cohort, and axial elongation was similarly much higher in the COVID cohort. This indicates faster myopia progression during that pandemic lockdown period. And this was coupled with a 68% decrease in outdoor time and a marked increase in screen time by the children. So when talking to parents, perhaps the first thing to establish is that a child's eye will continue to grow while they are growing. However, what we are all trying to do is stop rapid myopia progression, because rapid myopia progression will lead to the development of high myopia in adolescence and adulthood, and increase the risk of future visual impairment as an adult. So at any point when a person is myopic, some lifestyle modifications may assist. And these include setting the daily limits on the use of digital devices, particularly when a child is young. And there are timers inbuilt to most of these devices, which can be used to help monitor screen time. There should also be daily limits on study and homework and academic coaching, particularly when a child is young. And increasing outdoor time needs to be done to offset that time in near work and screen time. And so we have to aim for either active or passive time outdoors to offset that time in near work. Parents should share in these activities and help model a healthy lifestyle to their child. And that may encourage children to develop and continue that healthy lifestyle into adulthood. You should also encourage regular comprehensive eye examinations to monitor myopia progression and, of course, eye health, particularly as the adolescent moves into adulthood. So in summary, behaviour modifications are likely to have a significant impact on myopia progression, and they should be undertaken even if other interventions are being used to slow myopia progression. Key modifications are increased time outdoors while limiting near work and indoor time, including screen time. Parents need to be educated, as well as adolescents and adults, that it's important that they manage their myopia progression and to balance the amount of time that they're spending on near work and screen time as well as time outdoors. Governments do need to look at schooling policies to avoid heavy academic workloads for children, particularly when they're young. And Taiwan and China have, while facing major rises in myopia and the prevalence of high myopia, have acted to increase time outdoors while limiting the use of digital devices and homework and study load. And these are all important factors that need to be considered when managing myopia progression. Thank you for listening to my talk.
Okay, so I don't know what to say really. I'm learning so much. Kathy, thank you so much. I know you couldn't be with us because it's like in the middle of the night in Australia. Okay, so we're going to do about a 2-3 minute panel discussion before we go on to the next talk. There are lots of questions coming in, and I'm going to try and sort of bunch them together and then ask all the panelists their views. One is, how much screen time should we tell parents when a child has developed early myopia? So like let's say he's an 8-year-old or she's an 8-year-old, -2, how much screen time should we limit? That's one question. Sorry, I think I lost you for a minute. Is there a good viewing distance that you suggest that this is the viewing distance that you should look at a tablet, a laptop, or a screen? So I'm actually going to start off with Erin. Do you want to take that first?
Sure. As far as how much screen time to limit, I don't know that there's necessarily a number. It's interesting because we'll have parents and children come in, and obviously the parents are in favor of me telling their child to get off their iPhone or their tablet, things like that. And the children are there smirking, also saying that, whether or not I say it's okay. But we also have to be realistic. We live in a digital age, and so there's only so much, there's only so much we can limit, right? Kids now are doing online learning still in some aspects, and so obviously, in order for them to advance academically, they still need to use screens and tablets and whatnot. So I do at least make the recommendation to limit screen time, take breaks as needed. But there's not necessarily a certain number of hours that I tell the patients.
Okay, so I think that's fair. I think we probably all agree, for the sake of time, because we are running a little bit behind. Ian, is there a viewing distance that you tell them that, less than 20 centimeters, or what do you tell them about viewing distances?
Well, I think we need to face the fact in relation to screens that there's actually no evidence that reading a book is more or less dangerous than viewing a screen. So there's no point in stopping children using screens and letting them read books. Whatever limit you set on screen use, and I'm all in favour of it, I see the effects on my own grandchildren in all sorts of ways. But the aim of the suggestion has to be to stop children doing near work and get them outdoors.
Okay, Mark, any comments on that, or Cheryl, no, anything to add?
Frequent breaks are important for any near work. So generally, I would recommend them to take eye breaks every half an hour of any intensive near work, rather than the total amount of time they can spend on near work.
Okay. All right. Well, look, for the sake of time, Mark, I'm going to get you to address some of this in your talk as well. But it gives me great pleasure to introduce Mark Bullimore, who is adjunct professor at the University of Houston, College of Optometry in the USA. And Mark's going to talk about overnight orthokeratology. And I promise everybody in the Q&A that you're putting in, we'll try and cover as much as we can in the next panel discussion. Mark, all yours.
Thank you, Ken, and thanks for the invitation. if you see the QR code at the bottom of the slide there, that will take you to some of the references I'm going to use today on my website. I'll show that again at the end of the presentation. I do have some disclosures. I make my living working with companies large and small. And if you're in the know, you'll notice that some of these companies have an interest in myopia. So just to sort of lay the groundwork here, we're going to be talking a lot about evaluating the efficacy of myopia control today. But there are certain things that we like to see in our evidence-based world. We like to see randomized clinical trials that are preferably at least 2 years in duration. We like to see masking where possible, but with overnight orthokeratology, that's not possible. We like to see measures of cycloplegic autorefraction, and we like to see measures of axial length. And most of the time, we would expect changes in autorefraction, changes in myopia to be correlated with changes in axial length. And for the sake of argument, since I'm going to be presenting most of the data in millimeters, that corresponds to 0.2 or 0.25 diopters. I also have a strong preference for talking about absolute values rather than percentages. Now, when it comes to evaluating myopia control methods, axial length is becoming the method of choice for a number of reasons. It's more strongly associated with visual impairment. With our modern optical biometers, it does not require cycloplegia, and it is exquisitely sensitive and much more sensitive than a measure than autorefraction because it's exquisitively repeatable. And of course, a lot of the things, including orthokeratology and to a lesser extent atropine, will affect the optics of the eye and therefore confound any measures of refraction. The other thing I want to point out, again, from the paper on the right, which is on the website, and you can also find it fairly easily, it's open access, the treatment effect for pretty much anything we do to slow myopia is greatest in the first year. When you look at the cumulative reduction in axial elongation that is imparted by a treatment, and these are all results largely from clinical trials, you see that they have this sort of hockey stick shape. You get a more dramatic slowing of axial elongation in the first year than you do in subsequent years. And we'll come back to that in just a minute. So what about Ortho-K? To use a cliche, this is not your father's Ortho-K because there was a revolution some 20 years ago where three things converged to give us a much better product and a much better modality. These include reverse geometry lenses. So unlike a conventional contact lens, the secondary curve is actually steeper than the base curve. So that allows greater stability and centration. We have corneal topography instruments that allow us to exquisitely assess the change in the corneal topography. And also we have highly gas permeable materials that allow the potential for overnight wear, which of course is crucial for this modality. Now, the first presentation, or so the first publication of the effect of Ortho-K on slowing myopia used a historical control group, but you can see this field is only about 17 years old. What you can also see here is that where the total slowing is about 1/4 of a millimeter, most of the slowing occurred early on in the treatment. The same researchers conducted a randomized clinical trial and essentially found the same treatment effect, a little over 1/4 millimeter here. So that corresponds to maybe 0.6 diopters or so of slowing. Now, there are multiple meta-analyses on overnight orthokeratology. Here's one, but a hallmark of them is the results are very consistent across lens designs, manufacturers, and indeed geographic locations. So it doesn't matter whether a study was conducted in Europe, the US, or Southeast or Eastern Asia. The treatment effect is about 1/4 millimeter over 2 years. So going back to that figure, summarizing a whole host of studies, where does Ortho-K fit in that galaxy? And you can see that Ortho-K does pretty well. It's among our most effective treatments. Now, longer-term results also exist, and like all of the treatments that we observe, there is a tapering off of efficacy over time. But unlike atropine, we have many years of data from these two studies on overnight ortho-K showing a slowing of myopia or slowing of axial elongation of about 0.4 millimeters. These are the greatest effects that exist in the literature at the time of me speaking. Now, I noticed on the preliminary slide that not many of the audience, or at least the respondents to the survey, are practicing ortho-K or indeed prescribing any sort of contact lenses for myopia control. And one of the reasons may be that for that is concerns about the safety. I've been fortunate to lead two studies, perhaps the only two large studies, looking at the incidence of microbial keratitis in overnight orthokeratology. The first was mandated and indeed approved by the FDA. And as you can see on this slide, based on a retrospective cohort of patients, which about half were children, we found an incidence of around 8 per 10,000 years of wear. Now, 2 cases occurred, both in children, and neither resulted in a loss of visual acuity, but that means the incidence of children is, of course, slightly higher. We did a second study earlier this published, I think last year, in another part of the world. And this was based on a case series or a registry of cases of microbial keratitis in children alone. And you can see about half of them were associated with contact lens wear, and of those 5 associated with overnight orthokeratology. And based on our estimated number of children wearing ortho-K in the catchment area, the incidence was around about 5 per 10,000 years of wear. So I've talked about the slowing, I've talked about the risks. In this paper that was published in the Academy of Ophthalmology journal last year, we quantified and compared the risks and benefit. And our conclusion is that the benefits of myopia control with contact lenses and other modalities far outweigh the risks. And this is the summary graph that I alluded to earlier in the discussion, showing that across a range of ages, each diopter of additional myopia results in a 30% increase in the cumulative risk of visual impairment. These data are based on the Tiedemann study, and their criteria for visual impairment in that study was 20/40 or 6/12. So looking to the future, what are some of the unanswered questions? And recently, the BCLA got together a group to produce a series of reviews, and one of these, as part of the CLEAR portfolio, was on ortho-K. So what do we know and what do we not know? We do have a hint that ortho-K is more effective at higher levels of myopia. So you can see here at the top, the eyes treated with ortho-K, the ones with higher levels of myopia show a less change in axial elongation, or in this case, vitreous chamber depth. We can use ortho-K to partially correct higher levels of myopia, and we can achieve very similar levels of slowing of axial elongation. We're still exploring how manipulation of central and peripheral zones might alter the efficacy of ortho-K in slowing axial elongation. And here's one study that isn't necessarily reflected in the entire literature, suggesting that a smaller optical zone is more effective in slowing axial elongation. And then, of course, atropine can be used as an adjunct therapy with any optical modality. And we have a number of studies that have been published looking at the combination of atropine with ortho-K. And atropine has a modest additive effect, although I should note that this is 0.01% atropine. But what you can also see is the benefit of adding atropine to the therapy is more pronounced at lower levels of myopia than it is at higher levels of myopia. So I've given you a little bit of a snapshot of the world of orthokeratology. I do consult with companies including Johnson & Johnson Vision and Cooper Vision who have interest in this field. And again, the QR code will take you to some of the papers I discussed here, and I'm happy to answer questions today, or you can email me or reach me through my website. So thank you, Ken. Back to you.
Mark, thank you so much. Ever since I've been listening and reading the work that you and your group have done,
I think we might have lost Ken there for a minute. Or have you lost me? Well, Ken's obviously saying some very nice things about
slowing myopia in jet. Oops.
We lost you there for a minute, Ken.
Lost him again.
So why don't we go straight on to Erin and allow her to give her presentation, and hope Ken can be...
Southern California. Can you hear me?
Yep.
Okay. Southern California College of Optometry. And Erin, I'm really looking forward to this talk, because it's an area that I don't know very much about. So take it away. Thank you so much.
Perfect. Thank you so much, Ken. And thank you to all the organizers for inviting me to be here with you today. So I've been tasked with talking about daily wear soft contact lenses that are used for myopia control. And here are my financial disclosures. So the first question we often get is, when can we start myopia management, and specifically with soft contact lenses? And the answer to that is really as soon as the child is able to handle contact lens wear, being able to care for their lenses appropriately and minimize their risk, then that's when we want to start any sort of intervention. The other thought is that we can also talk to these parents about myopia management even before their child becomes myopic. We know that there's obviously a genetic component to myopia development. And so if either parent is myopic, or there's any sort of family history of high myopia or retinal detachment or myopic maculopathy, then we can start those discussions. And this is obviously beneficial to even mention myopia management before, so that the parents can start thinking about it. The next most common question we get is, even at the beginning of when we're going to start myopia management, is really, how long is my child going to be wearing these lenses? And we know that myopia can continue to progress into early adulthood. And from the COMET study, we see that 50% of children's myopia tends to stabilize by age 15 and 75% by age 18. But if we kind of flip this around and think about it from the other way, that means that 50% continue to progress after age 15, and 25% will still continue to progress after age 18. The most common reason that we may potentially take people out of these myopia management lenses is really because their activities and requirements in daily life require more sharp visual acuity, or more, they need better visual performance from these lenses. And so with the multifocality and higher order aberrations, sometimes these are inhibiting factors. And so when these kids are starting to learn how to drive, or sports become more competitive, then that may be a reason why we take them out of the lenses. This is often commonly seen also with orthokeratology, because when these kids are not sleeping enough because they have heavy workloads and high academic demands, then they're not going to be able to get full correction in Ortho-K lenses. We want to continue to still monitor their progression though after we take them out of some of these lenses. So I usually still continue to monitor for at least a year following, to look for any sort of rebound, or to make sure that they've actually truly stabilized. And if we need to, we can always restart treatment. So once we decide that contact lenses are the way to go, there's several factors as far as deciding between orthokeratology versus a soft contact lens. And the first one is always the child's age and their maturity level, again, whether or not they're able to handle contact lens wear. The next is also the parents' level of comfort with or control over the lenses. So some parents will prefer to have complete control over when their child wears the lens. And so they'll opt for Ortho-K because they can put the lens in before the child goes to bed and take it out in the morning. So the child's not going to school with the lens. Whereas others are more familiar with soft contact lenses because they themselves are soft lens wearers. And so they're more comfortable with that modality and okay letting their child go to school with the lens. Another limiting factor is always the refractive error. Ortho-K, currently the FDA limits in the US are -6 diopters of myopia and 175 diopters of astigmatism. And then the add power and the amount of peripheral plus that is achievable in the lens types varies. And then of course the safety profile. So parents are always concerned about the safety of contact lens wear. In a recent analysis that looked at several different studies, they found that the risk of microbial keratitis in kids is least in daily disposable lenses, slightly more in reusable soft lenses, and then slightly more in orthokeratology lenses. But overall, the safety profile is relatively the same. There's also a misconception that the risk of contact lens wear is greater in children than it is in adults. And so the CLAY study actually looked at different age groups and found that the risk of any sort of corneal infiltrative event is actually greatest in the 18 to 25-year-olds, so those young adults that may not be having the best hygiene or care habits, and a lot lower in our 8 to 12-year-olds, which is really the group that we're primarily using these treatments on. Once we've decided that soft lenses are the way to go, then we have a couple of different options as far as type of soft contact lens. So some of the factors that go into this decision-making are whether or not, again, they're able to handle a reusable lens or whether a daily disposable is the better option for them. And associated with that, again, is the cost of lenses, because obviously the cost of a daily disposal is going to be greater than the cost of a reusable lens. Another factor is the amount of astigmatism. So higher amounts of astigmatism obviously need some sort of toric correction, and not all these lenses offer toric modalities. And then the corneal curvature is more relative to orthokeratology, but also in some soft contact lenses, some offer multiple base curves versus others that only offer one base curve, one diameter. In the US, we're a little bit limited as far as the soft contact lens options that we have, but recently there has been an FDA-approved dual focus myopia control soft contact lens that is FDA-approved with the indication for slowing myopia progression in 8 to 12-year-olds. Besides this lens, all of the other lenses that we're using are considered off-label. But children adapt really well to these lens modalities. So sometimes people are concerned about the multifocality and the vision, but I will say that children are very adaptable and don't necessarily have visual complaints. So this one FDA-approved soft contact lens that we have in the US is the CooperVision MiSight lens. This is a daily disposable lens, and you can see it has several concentric rings. So those light purple rings are the correction zones. Those are correcting for your distance myopia, allowing you to have clear vision. And then the darker purple zones are the treatment zones that are creating that myopic defocus. Again, this is the only soft contact lens that's approved for myopia control in the US. And recently they expanded their spherical powers to up to a -10, but they do not offer toric options at this time. So one of our off-label lenses would be also made by CooperVision. This is the Biofinity or the ProClear multifocal lens. We're using the center distance design. So they are offered in both center near and center distance. For myopia management, we're using the center distance design. You can see that means that the central 1.5 millimeter zone is again for distance correction, and then the add power increases as you go out into the periphery. The ProClear is the older lens, so it is a hydrogel material. It does have 2 base curves, and it goes up into higher add powers of actually up to a +4, whereas the Biofinity, a little bit newer, is a Sci-High material and then goes up to a +250 add power. And these are often used for our toric patients because both of these now have toric options. Another daily disposable option that we have in the US is the Natural View lens. This is a hydrogel. The thought the kind of design behind this lens is that there's a absence of any sort of central spherical optic zone, but then there's a rapid and kind of continuous increase in plus power as you go away from the center, and sort of creating like a virtual pinhole effect that allows you to have an extended depth of focus. They have a universal add power for all of their lenses, so it's effective up to a +3, and there's a little limited data as far as myopia management on these lenses. So outside of the US, there are a couple other options. The Swiss Lens Relax is CE marked in Europe for myopia control in 8 to 18-year-olds, and this utilizes a hyperopic defocus control, similar to the other multifocal designs where they're trying to trying to bring in those peripheral light rays and allow for myopic defocus. The Essentia lens is a reverse geometry soft contact lens that has a progressive +2 add power on the front surface. And then the Milo lens is a concentric extended depth of focus design. And this is actually completely customizable. So it offers different add powers, different base curves, and different diameters. So I wanted to go over just a few cases that which highlight our clinical decision making. So in this first case, I had a 10-year-old boy come into my office, relatively high myopia with higher amounts of astigmatism and also relatively flat keratometry values. And his mom accompanied him to the visit, and she shared that she is a soft contact lens wearer. So this kind of led us down the path of choosing soft multifocal lenses over orthokeratology. One, due to the familiarity of, his mom would be able to help him as far as wear and care of the soft lenses. But the other fact is that he does have flat keratometry values. And so if you're starting already with a flat cornea and you're trying to flatten it even more, there are obviously limitations there. And so I was realistic as far as what the expectations would be with Ortho-K in this case. And then between our different lens designs, we went with the Biofinity Toric Multifocal. Again, that's center distance reusable monthly lens. And this was primarily due to the astigmatism because it does offer a toric version. And then we also started with a +250 add power, and this was based off of the BLINK study. So the BLINK study is a collaboration between Ohio State and the University of Houston. We enrolled up to almost 300 children that were 7 to 11 with up to 5 diopters of myopia. And they were randomized to one of 3 groups. So either a single vision Biofinity spherical lens, medium add power, so that's the Biofinity center distance with a +150 add, and then a high add that was the same lens with a +250 add. And after 3 years, they found that the +250 add was more effective than both the +150 and the single vision lens as far as slowing myopia progression in terms of both the spherical equivalent refractive error and the axial length measurements. But also interestingly, they found that the +150 was not necessarily different than the single vision lens. So realistically, this study is telling us that we need to be prescribing at least a +250. In our second case, I had a 7-year-old female who had a relatively low myopia that was coming in with regular K values, and both of her parents were myopic. And this is interesting because this parent actually presented when the child was 4 years old without her child. So she came in by herself for a consultation just to learn more about myopia management, because that was the level of concern that she had for her child's potentially developing myopia. There's a thought that with these lower levels of myopia, whether or not we're getting more myopic defocus with a soft contact lens that has like a set add, like +250, versus trying to do orthokeratology, where the add is usually, or the amount of peripheral plus is usually relative to the amount of myopia that you're correcting. In this case, the parents were also obviously extremely motivated. And so we ended up choosing the MiSight lens for this patient, one, because it was a daily disposable lens. And so the parents felt more comfortable about their 7-year-old's ability to handle lens wear. And then she also has a spherical prescription and a low prescription. So this was really a slam dunk case for the MiSight lens. My last case is a 9-year-old boy who came in, again, low, moderate levels of myopia, and he was actually a competitive baseball player. And so he needed to be able to see the ball clearly, these fastballs coming at him when he was at bat. And then the parents also mentioned that cost was a factor in this situation. So because cost was a factor, we kind of went the route of an aspheric multifocal, a monthly lens. And we wanted to be realistic and discuss those visual expectations because he was playing sports. As I mentioned with the Blink study, we started with a +250 ad. There may be instances where you do have to drop the ad power in order for the patient to adapt to the lens, but I always start at the +250. So ultimately, we see that soft contact lens daily wear options are a good choice for children who are wanting to pursue myopia management. And unlike our presbyopes that wear multifocals, our children are much more likely to be able to adapt to these lenses pretty quickly, these different modalities and lens designs. And then you can see there's not a whole lot of options on our market, depending on where you practice, but that means that we can become, relatively quickly become pretty experienced with these different types of lenses. And just a general tip on when I approach myopia management with my patients, I usually go over all of the options. So I will still talk about Ortho-K and atropine, but I do make a clear recommendation because that's why your patient is coming, to see you and wanting you to take care of their child's vision. So thank you. And I'm sure there's a question and answer session after this.
Fantastic. What a great overview of all the different contact lenses in different parts of the world. Just what we needed. And I think panel discussion, but we're going to go with our last presenter for today. It gives me great pleasure to introduce Dr. Cheryl No from Singapore. She's affiliated to the National University of Singapore, and she's going to give us some sort of more detailed FDA study perspective on contact lenses for myopia control. Cheryl, all yours.
Thank you, everybody, for still staying with us, and to Ken and WSPOS for the invite tonight. So these are my financial disclosures. So the dual focus contact lens clinical study was actually divided into 3 parts. In part 1, the children aged 8 to 12 were randomized either to the test lens, which was the dual focus contact lens, or a control lens. And in part 2, those that were previously on the test lens continue on the test lens for another 3 years, whereas those that were on the control lens would then switch to the test lens. And in part 3, children who were all wearing the test lens would then switch over to the control lens. So this study was conducted in 4 sites worldwide in UK, Portugal, Singapore, and Canada. So you can see that the baseline demographics in part 2, they were largely similar, except for the baseline spherical equivalent refractive error and then the axial length as well. And this was similar for part 3 as well. And if we look at the discontinuations and adverse events for part 3, we had some non-significant lens as well as non-lens related events. And if we look at the ocular health summary findings, there was 1 serious event that was non-contact lens related and 5 incidences of a higher than mild slit lamp finding across the entire study. So here we have the cycloplegic refractive error data in part 1. So you can see here the control group in orange versus the test group in purple. There is a there's a statistically significant difference between them. And when we moved on to part 2 of the study, those that were on the test lens continued to maintain the gradient of the curve, whilst those that were switched from the control lens to the test lens, you can see that the change in cycloplegic refractive error actually slowed down. And what we want to see in myopia control studies is a strong correlation between the axial length as well as the refractive error, which you can see here. There's a difference between the test lens in purple and the control lens in orange in the first 3 years. And we see a slowing in the change in the axial length in those that were previously on the control lens and then switched to the test lens. So in all, in those who were in the control lens and then switched to the test lens, in the part 2 of the study, they actually progressed less than 0.2 mm through the final 3 years. So we look at the comparison of the adjusted change in spherical equivalent refractive error within the study parts. There was a significant difference in part 1 as we had expected. And those that were in the test lens on the second part of the study, you can see that the gradient of the curve maintains, whereas those that were previously on the control lens and switched to the test lens, they were not significantly different from those that were on the test lens for all 6 years. So it's actually never too late to start your child on the dual focus contact lens. So if we compare the adjusted change in axial length within the study parts, once again, we get very similar correlation with the spherical equivalent refractive error as we had seen in the earlier slide. So once again, the difference when they were in and out of treatment was significantly different. So if we look at the population distribution of eyes, we can see that 23% of the eyes that were in the test lens for 6 years were actually refractively stable, with a total refractive change of only minus 0.25 diopters over the entire 6-year study. And if we look at the 6-year change in contacts and eye growth, we can see that the 6-year progression in axial length in those who were in the test lens for all 6 years actually matches the 2-year progression for the original control. That is actually a 4-year gain in the key period of eye growth. So in the end of the 6-year summary, we find that the 6-year total progression matches the first 2-year progression in the control group, and 23% of the eyes that were in the treatment group for 6 years showed stable refractive error. And this is currently the longest continuous soft contact lens study for myopia management. So now the question was, if we stop their treatment, would these effects still maintain? And hence this was the why we did the part 3 of the study. So if we look at the change in axial length, in part 3 of the study, when both groups were taken out of the test lens, the gradient of the curve remained largely the same. However, we compare the analyzed change in axial length. We wanted to do this statistically to see if you're getting a rebound. So we don't have an age-matched normal in this analysis, but we do have data from the same population as when they were younger. So they are actually essentially acting as their own control in this study. And this is represented by the orange bar on the left. So as you can see, once they were out of treatment, the effects of the contact lens were unfortunately not maintaining, but perhaps this was not enough to consider it a rebound. So there's no evidence currently at the end of the 7 years that untreated eye growth following cessation of the treatment actually rebounded to reverse any of the accumulated treatment with the dual focus lens observed in the prior 3 and 6 years. And the eye growth actually reverts to an age average annual elongation rates. And it still remains to be proven that there's no rebound that is generalizable to any treatment cessation of optical designs for myopia management. So in the post-approval US study, it's now enrolling at 5 US clinical sites, and there are 2 parts to it, where they will either be randomized to the dual focus or the control 1-day lenses for 3 years. And in part 2, all subjects will wear the control lenses for 1 year. Thank you very much.
That's fantastic. Thank you so much. That was very, very useful to see that laid out like that. Thank you. So we're going to go to a panel discussion now, and we have about 12 to 15 minutes. And I've been looking at the Q&As. So let's go to the Orthokeratology question first. Mark, there was a question about, does Orthokeratology reduce axial myopia? Now, I think I know the answer to that question, but part of that question, somebody else asked, when you stop Orthokeratology, do you get rebound?
So yes, absolutely. Orthokeratology slows axial elongation in myopia. In terms of rebound, rebound is probably one of the most under-researched areas of myopia control. We know from the ATOM study with 1% atropine, we saw a profound rebound effect in the year following cessation of the 2-year treatment. But of course, ATOM was a unilateral study, so that may have influenced the rebound. We don't see rebound with very low concentrations of atropine. We do see it in younger kids with 0.05%. With Ortho-K, there's really only one short-term study, which I find inconclusive, in part because children weren't randomized to discontinue. They elected to either or not. So there was a little bit of regression towards the mean. So I think we have to be aware of rebound, but certainly my mantra will be the older the child, the less likely that you're going to observe rebound.
Okay, so Ian, are you still with us? Because I have some more behavioral intervention and outdoor questions. Are you still with us, Ian? Okay, well, I'm going to put them to the panel anyway. Question number one is it just that you're not doing accommodative work side? Is that the drive? And my understanding is that actually, no, it's lux, the actual exposure of light, and it's not UV light. It's lux rather than UV light. Is that your understanding, Cheryl or Erin, Mark? Is it UV light or is it lux? That's another question.
I believe it's actually the lux from previous studies on outdoor time.
Yeah,
that's my understanding.
Yeah, I mean, accommodations had a rich history in being blamed for myopia, going back to sort of people contemplating that the myopia was lenticular, which it's not. The idea that it increases intraocular pressure, which it doesn't. And then we had maybe a 20-year obsession with accommodative lag and myopia being caused by sort of sloppy or inaccurate accommodation. That's been largely set aside now due to a sort of bulk of evidence, in part that accommodative manipulation with multifocal spectacle lenses doesn't appear to have a great deal of effect on the slowing of myopia. So in terms of the broader question, it's probably not accommodation. It may be the fact that when we go outside that we have a much flatter dioptric field compared to inside, where I'm sitting here looking at my computer at about 40 centimeters. I'm not accommodating, of course, but I have things in my peripheral vision and in front of me that are very different distances, and it's possible that that's the trigger. But accommodation per se, no.
So, Erin, Cheryl, question: at what age can you start orthokeratology? What age do you start? Would you consider orthokeratology or contact lenses? Either. What age would you start? I think people clearly are wondering, how young you can start. I think that's what the question is coming from.
I mean, so part of it is, how the parents are going to be involved. If the parent is, going to put the lens in and take the lens out and clean the lens properly, then, I mean, you could start relatively young, 5. I have some on 5-6-year-olds as well. It's a different story if the parents don't want to be involved at all and, are going to leave it to the kid, then obviously it's up to them on how well they can handle and clean the lens and whatnot, care for the lens.
I also think it depends on the individual, the child, how mature the child is. If the child is able to handle the contact lens and personal hygiene as well. Of course, like Erin said, parental motivation, parental encouragement is very important. Generally, I find that girls are able to do it at a slightly younger age. So rather than boys tend to be a little bit more hesitant in learning how to use the contact lenses. So for girls, I would start to recommend above the age of 8. For boys, maybe a little bit older, 10 and above. But I guess that's not a hard and fast rule. It really depends.
Mm-hmm.
So let me, I'm going to be very honest with you. I'm a pediatric ophthalmologist. I don't understand contact lenses as well as Erin, you or Mark or Cheryl, you do. So I need to work with somebody, and I have a great optometrist I work with. How parents will ask me, how long do we need to continue orthokeratology or contact lenses? So let's say you have a 7-year-old girl, you've decided that parents have decided they don't want to use drops. You've done behavioral intervention already, and the decision is to go to a contact lens therapy. How long do you tell the parents that the child is going to need contact lenses, orthokeratology, or the newer technology of contact lenses that's been discussed?
So, I mean, as I mentioned about the COMET study, we know that they're probably going to continue to progress until, half of the people until at least 15. So I usually say until, kind of that teenage years, 15 to 18, which is a long time when your child's only 7. So you're kind of committing to it for the long haul. We have the patients come back every 6 months, and we're monitoring axial length and those visits. And so if we do see some sort of stabilization over a long period of time, then we can have that conversation about maybe taking them out. And then, like I said, once we take them out, continue to monitor for another year to assess whether or not there is progression after that. And if we need to go back into, one of these contact lens modalities, or if we can continue on in like a single vision correction.
So before I pull in Mark and Cheryl on that, going on from what you just said, there was a question: do you always do 6 monthly follow-up, or are there times where you would go to 3 monthly follow-up because you're worried, or 12 monthly follow-up? Can you address that?
Yeah, so part of the reason 6 months is usually our standard. We do sometimes have visits earlier, 1 month, 3 month, things like that. Depends on the fitting process, where we are, how stable the child is. We usually don't necessarily make changes just based off one period of 6 months, because we know that there's also seasonal variation. And so maybe they grow at certain points because, grow more because it's the winter time versus growing less during the summer. And so we don't, it's not like we're always quick to change, right? And so if we do it every 3 months, how much we're getting more data, but I guess are we really going to act on that is another question.
So Mark, before I come to you about the contact lenses, here's an interesting question. Somebody asked, if you live near the North Pole, of myopia higher because you're in darkness more of the year? I don't think there are any studies about that. Anybody got any? It's a great question. I mean, it's a great question.
There's some really nice data out of Norway that suggests that the epidemic of myopia is not occurring in that part of the world. Of course, they have, unlike Singapore, where you have a constant amount of sunlight every day of the year, or constant amount of daylight. It varies dramatically in the up close to the Arctic Circle. So these children are bathed in darkness much of the winter and bathed in sunlight most of the summer. But the Nordic countries tend to have a much more outdoorsy lifestyle, cycling, walking, and such like, and that probably plays into it. But it would be a fascinating study to go and look at people up in the far north. Of course, some of the early data we had on myopia were from Eskimos, and the introduction of a more formal schooling curriculum resulted in an increase in the prevalence of myopia.
Do any of you ever tell your parents? I mean, look, I'm sitting in Mendoza at the moment, and it's 35 degrees centigrade, but I flew from Pittsburgh and it was -1 degree centigrade. Do you ever tell your children if you...
I think we lost Ken again. I think certainly in Europe, it's never too cold to go outside. Just wrap up a little warmer and off you go. Ken, we lost you. So why don't you say something and see whether you're back? No.
So the reverse is true in the tropics, where we have sunlight, like you said, most of the year, but the kids don't want to go out because they complain it's very humid. It's really hot, so they don't like to spend time outdoors, which is why I think our myopia rates are really high here.
Yeah, we need to come up with, we need to patent some sort of personal child-based air conditioning unit so they can be bathed in cooler, drier air as they get their outdoor activity.
Right.
So
Ken, you're
sorry, there are lots of questions coming in about contact. Oh, Ian, you're here. Thank you so much.
I
I
managed
really,
to get back.
I know it's in the middle of the night. We had some questions about whether it was UV light or whether it was lux, and we all agreed that it was lux, not just the UV light. It was not the UV
It's
light.
definitely not UV light.
Perfect, perfect. So let me ask you that we also had this question about you know, when you see okay, I know some of you are not seeing patients, but how would you advise the practitioners who are listening to this webinar when they see a child who is 6 years old, has myopic parents, and the child's -1/2? What, in the last couple of minutes, everybody, what would you advise those parents? I'm going to start with you, Ian.
Okay, well, I should say I have no clinical qualifications.
I know,
So
and I made that
Like-
clear.
take whatever I say with a grain of salt. Look, I think the obvious thing at this stage, when you've got a child who may not yet be myopic, but you regard as high risk, is to try and get them outside as much as possible. So I have to say, from my experience in working a lot in China, I hear the same statements about how the children don't like going outside. And my experience is the children actually like going outside. It's the parents or the teachers who don't want them to go outside for all sorts of reasons. So I think when you let kids play, kids play. And even in quite hot and sticky climates, they like doing that outside.
Okay, thank you. Let's go to Cheryl. What do you tell that parent?
So I think behavioral modification, lifestyle modifications are very important. Besides outdoor time, good eye care habits, also always get them to take frequent eye breaks, reduce unnecessary near work. Yeah, and of course, make sure that they optimize their vision. So make sure they always do wear their glasses.
Let me
Erin, what about you?
let me jump in here. I
Yeah,
think
go ahead.
about a freshly minted half diopter myope who's 6 years old. I mean, what I would tell a parent is, your child is myopic. It's going to progress. They have a risk of developing high myopia, particularly if they're an Asian child. So we should at least have a conversation about what could be done. And while I are hesitant to pronounce that myopia control is the standard of care in any part of the world, I think we have a duty to inform and have the discussion with the parent so they're aware of what the potential consequences are and what can be done.
Perfect. Erin, what about you?
Yeah, I agree with everything that's been said. Behavioral modifications first, but I mean, if they are already half diopter, then yes, they're already myopic. And so at that point, you can have the conversation about different treatment options. Usually, if they're not ready for contact lens wear, then that's what leads us down the route of atropine. In the US, although in several other countries, you already have spectacle lenses available, certain spectacle lenses for myopia management. We don't have that in the US yet, but I think that would also be a great option for somebody who's not ready to wear contact lenses.
Okay, so we're
Gone again.
The Argentinian gremlins have got to Ken again. But this is what happens when you plan a wine tasting.
For those of you who for the
professional obligation. Not sure we're going to get Ken on. Bradley, do you want to come on and take over?
The panelists on tonight, on today or morning, wherever you are, to come back, and we are going to address to the questions, so don't panic if we didn't answer them. And I also want to say that the WSPOS launched a myopia consensus statement in 2016. It has been updated. It will be released in the next 10 days by December the 6th. And everything that you've heard will be addressed in that in terms of what we think is available. So look out for that. If you've been listening to the webinar today, you need to listen tomorrow, and then you'll get the whole overview. We on purpose wanted to talk about contact lenses, behavioral interventions, the impact of myopia today, and then tomorrow we'll be talking about the other interventions. So you gotta tune in tomorrow if you want to have the full picture. So in the last few minutes, let's go to the ARS questions. Based on what you've learned today, and remember, you don't have to be the one necessarily using the contact lenses. You need to work with people who know how to do these things properly. How confident are you now in your ability to manage and treat myopia progression in a patient younger than 8 years? Younger than 8 years. So if you'd like to answer that. And let's see, remember to hit send so that we can see. Well, we've increased the level of confidence quite significantly. We have nobody who is doing the survey who says that they are not confident. So congratulations, panelists. That's quite, well, we have 1% now. 1% not confident, but much lower than it was. Okay, we're going to go to the next question. Based on what you've learned today, how confident are you now in your ability to manage and treat myopia progression in a patient between 8 to 12 years? Between 8 to 12 years. Now, do remember, I know that you've only seen one webinar, you've got part 2 to come tomorrow, but how confident are you? Again, the level of confidence has gone up. And again, panelists, thank you very much. You've made a big difference. Thank you so much. Okay. Question number 3. Based on what you've learned today, how strong is your understanding of the latest treatment options for myopia management, including orthokeratology and multifocal soft contact lenses? Now, remember, the question is not how confident are you in delivering that? How confident are you in your understanding? How much has your understanding changed? Very strong understanding is 17%. So we're now at 98% of having some sort of better understanding, which is phenomenal, absolutely phenomenal. Okay. I think that we're on the last question here. How significantly, oops. How much do you think that this has helped you improve your ability and myopia? Fabulous. Well, I want to thank wholeheartedly the panelists for making this amazing. There's only, well, you've significantly improved people's ability to manage this condition. Somewhat, well, significantly, very significantly is running at 70%, and somewhat significantly 27%. So there's a small number who still need to listen to the webinar number 2, I think, before they feel more confident. But look, on that note, I want to say thank you so much. We're going to go to just a reminder that we have got webinar number 2 tomorrow. And that will really, really, I think, cement what you've learned today, and hopefully what you've understood today. It's been wonderful. I've really enjoyed the discussions. I want to thank again our supporters, Essilor Luxottica, our gold level supporter, Hoya, our silver level supporter, and Cooper Vision, our bronze level supporters, for this independent medical education program, a comprehensive update on myopia management. That's from the World Society of Pediatric Ophthalmology and Strabismus. So we're goodbye, namaste. I hope you have a wonderful day, and thank you so much. Erin, Cheryl, Ian, Mark, Ramesh, and Jay had to go off. Thank you, everybody. It's been a real pleasure conducting this with you. God bless.